I've just requested it.
Perfect.
For
Yeah,
possible
you should be
screen.
able to share now.
I hope you are seeing my screen. Yeah?
Yep.
Okay, thank you. As I have been introduced, my name is Yekonia. So I'll be presenting to you my study titled as the development and validation of machine learning model for predicting high-risk human papillomavirus infections among women aged 25 to 60 years attended cervical cancer screening in Tanzania from 2015 to 2024. And this will be my outline.
And just so you know,
Yekonia.
sorry to interrupt you, Yekonia, your presentation isn't in presentation mode, which is okay, but if you want to make it full screen, that would be nice.
Okay, now it's seen.
There we go. Yeah, that looks great. Thank you.
Thank you, thank you. So this will be my outline. And this is the list of abbreviation where we'll have HPV as high-risk human papillomavirus infections and MLL as machine learning model, some of most common abbreviation. Starting with the definition of term, we know machine learning, these are the algorithms that learn from complex data and enable them now to make prediction or decisions autonomously without explicit programming. And another key terms is HPV infections. This is the viral infections that affect either skin or mucosal epithelium, and they are likely to cause either benign or malignant lesions. So they exist in more than 200 serotypes, and some are high risk, some are low risk that may disappear in a few time. And we have high risk HPV infections. This will be our outcome, which is defined as human papillomavirus infections that are known to cause cervical cancer. They exist in almost 14 serotypes as listed here. So whoever will have either of these serotype will be defined as high risky HPV infection positive. Starting with the background, we know cervical cancer is the global leading for cancer-related morbidity and mortality among women. And these cancers are being attributed highly with the high-risk human papillomavirus infection, almost by 70% globally, and approximately 90% in Sub-Saharan and in Tanzania. So the burden of cervical cancer is high, but low and middle-income countries, they contribute to the higher percentage by about 81%. As we can see in Sub-Saharan Africa, almost 95% per 100 women are being diagnosed with cervical cancer per year, and more than 40 women per 1,000 women again are being diagnosed with cervical cancer per year, similarly in Tanzania. So we know cervical cancer is the leading burden, so the world has been working to make sure we reduce these cases to almost 4 cases per 100,000 per year by introducing this approach of vaccinating women at the age before 15, screening women who age 25 to 60 years by almost 70%, and 90% of those who will be detected with either cervical precancer or cervical cancer has to be treated timely. So on the screening aspect now, which is our major concern of today. Hello.
Sorry, go ahead.
Okay, thank you. So on the screening aspect, which is the main agenda of today, HPV DNA test has been recommended as the primary screening test, followed up with pap smear and visual inspection assays to appreciate if there is lesion in the cervical cancer. But in majority of low and middle income countries, they have been using VIA, which is visual inspection assay, instead of HPV DNA tested due to the cost implication. Now, to optimize the use or the allocation of these scarce HPV DNA test, the traditional methods like eligibility criteria and risk factor or risk score has been used to triage or to prioritize the scarce HPV DNA test, which is in contrast to the practice in high-income countries that applies or appreciate the use of machine learning models to personalize, to help they personalize the risk stratifications and decision support in order to optimize this or to allocate women for further investigations. And machine learning, we know, they offer a complex ability to deal with the complex data manipulation together with non-linear data, unlike to the traditional one that has been used in low and middle income countries. And these are the literature review, which has showed that majority of studies that has applied machine learning models either to predict high risk human papillomavirus infections or cancer have been doing well in terms of discrimination ability. And these are the sum of factors that has been reported to contribute to the high risky human papillomavirus infections. The same applies to this page also. We see few studies has been conducted in low and middle income countries, including one has been found to be conducted in Uganda. So we know that cervical cancer is a real problem, even in Tanzania, with almost 10,000 cases being diagnosed per year and about 60,000 cases people being died due to cervical cancer per year. And this screening approach has been kept into place in our setting, including the HPV DNA test and others. But due to the scarce and cost implications of HPV DNA test, even in our country, we rely on the use of VIA as the primary screening methods, which leads to majority of cases being missed earlier, and they result to be diagnosed in the late stage where we cannot save these people. Also, in Tanzania, to optimize the scarce resources, methods like risk score, risk factors, and even VIA has been used to prioritize the limited resources on HPV DNA test, which is the accurate one in determining or in identifying women with cervical cancer lesions. Now, considering the potential of machine learning model on predicting women with high risky HPV infections, limited studies has been conducted in our setting. So this study aims to develop and validate the machine learning model that will predict women with high risk human papillomavirus infections and recommend for further HPV tests and other advanced methods instead of relying on VIA and traditional methods. So these studies will inform the Ministry of Health, particularly on the use of machine learning model to identify women with high risk and to improve the resource allocations despite of the cost implication of this HPV DNA test. Also, this study will inform healthcare providers, health facilities together with non-governmental organizations to either use machine learning models to support targeted cervical cancer screening and even to go to the community to screen women and then refer to the setting that has high risk, that has HPV DNA testing. Similarly to the future researchers, this study will inform them, we highlight them on the potential of machine learning model together with informing the conduction of further studies to validate and to improve these models. This is my conceptual framework where the first part A demonstrates the common or the current cervical cancer screening framework, where we know people who might be exposed from these factors, including demographic, behavioral, or clinical factors like pallid and others, might have interrupted their cervical status, being exposed to STIs, then to HPV infection, then they might have high-risk HPV infection persisted for some time. When they go to the screening setting, we use the risk score of VIA, which is unlikely to miss some of the potential infected women. Then we refer them for further tests if they have been found to be positive, and if they are found to be negative, we will schedule them for the next visit. Now, our machine learning model will assist us to use the same exposures that facilitate, that expose women to be encountered with high-risk human papillomavirus infections. Then we will refer those women who have high probability of having high-risk human HPV infections, and then we propose the use of VR to appreciate if they have lesions or they don't have. If they have lesions, we will recommend for further HPV DNA test. And if they don't have lesions, we can prefer again to confirm with the HPV DNA test because our machine learning model has recommended. Otherwise, we will schedule for further visit. So my objective is to develop and to validate the machine learning model that will predict high-risk human papillomavirus infections among women of this age attended cervical cancer in Tanzania from 2015 to 2024. And my specific objectives, the first is to develop machine learning models for predicting a high-risk human papillomavirus infection. And the second objective is to evaluate the predictive performance of the trained machine learning models. And the third one is to identify now the predictors of high-risk human papillomavirus infection. Coming to the methodology, this is the secondary analysis using the data from the parent study, the data from two studies conducted previously. The first one is concept study that was prospective cohort and nested cross-section within it. And the second one is Gombo's ETL study that was the community-based study or cross-section study. The first study was aimed to study the natural history of human papillomavirus infection together with the performance of various cervical cancer screening method, while the second study was aimed to study the uptake of cervical cancer screening among women who are sexual workers. And the first study was conducted from 2015 to December 2019, while the second study was conducted in 2024. Both studies collected demographic behavior together with the reproductive and clinical data using questionnaire with the possible test of biomarker, especially HIV. And both studies confirmed the high-risk human papillomavirus infection using the PCR DNA test. And both studies excluded women with pregnancy who had history of cervical cancer and those who had the history of being diagnosed with those who had history of being undergone the procedure of abdominal hysterectomy. Coming to the current study, this will be the retrospective predictive modeling study of women aged 25 to 60 years. This study will include all women that were included in the parent study, but with the special focus, we will exclude women with missing outcome of interest. Also, because our data lacked some important information on HIV, important information regarding HIV status, so we exclude women with the HIV. And the ethical consideration we observed. Now, with regard to participant flow chart, the first study initially had almost 40,000 participants, so we exclude those with HIV and remain with around 3,100 people, while the second study also had almost 351. Once excluding those with HIV, we remain with 279, resulting to the sample that has been used in this study, which is 3,610. So high-risk human papillomavirus infection is our outcome. So it was coded as 1 or yes if the person has either of these 14 serotypes, and otherwise these women were coded as 0 or no. These are my exposures or feature, which ranged from demographic, like age, marital status, education, behavioral, age at first sex, number of lifetime sexual partners, use of alcohol and smoking, reproductive, in this case we had palliative, lifestyle, and the clinical findings we have BMI together with history of genital warts, history of syphilis. These were self-reported variables. This one is this was the data analysis and modeling framework or pipeline, where we have our data set. The first process was data pre-processing phase. The second one was training and validation. The third was model evaluation phase. So on data pre-processing, we had data preparation that include cleaning. There's 2 data sets, harmonizing the names of these variables, appending, looking for missingness. Also, we did imputations using the multiple imputation chain equation. Also, we did exploratory data analysis, scaling of continuous variable, encoding for categorical variables that had more than 2 options. Also, with the limited variables, we focused much on literature to choose the most important variables. We did multicollinearity, but we allowed our model to use their embedded approach to select the best features. So on training, we trained a total of 6 models, as listed there. We applied stratified 10-fold cross validations. That is our internal validations to train our model, and we allowed tuning parameters that are default from the current package within our programming language. On model evaluation now, we use there's like 7 parameters to evaluate the model performance using the cutoff point, the default cutoff point of 0.5. And on the feature importance, we decided to use the coefficients from Lasso. And we did decision curve analysis to check if this model will be of potential use in our daily screening, cervical cancer screening program. So coming to the results, on the assessment of missingness, we found that the highest variable with missingness was parity, which has 7.92% of missingness, and the rest has less than that. So based on our final participant we included, we had positive cases, high risk human papillomavirus positive cases of about 17.1%, and the rest were negative. And this is our table 1 that shows the characteristics of our study participant. We see we had the continuous variables like age, parity, age at first, sex, and BMI. These were normally distributed, so we used the mean and standard deviation to summarize them. And we had number of sexual partners. This variable was skewed, so we used the median and interquartile range to report it. Coming to the categorical variable, majority of women were married or cohabited. Majority of women had no or primary education. Majority of women were screened in Kilimanjaro, because this study was conducted in Kilimanjaro and Dar es Salaam in both 2 datasets. Majority of women also were non-smoker. Majority of women were non-alcohol consumers, by almost 60%. Majority of women had a partner who has been circumcised, by almost 93%. And majority of women had reported to have no sexual transmitted infections like genital warts, chlamydia, gonorrhea, and syphilis. Now, after training our model, this was the model evaluation performance. We had a total of 6 models, and out of all this model, the highest performance in terms of area under the curve was 0.69. In our this stacked ensembled model, gradient boost model, naive Bayes model together with Lasso. So our stacked ensembled model included almost 4 models like gradient boost, random forest, KNN together with Lasso. Out of these, all models, they had almost high accuracy. Majority of models had high ability of predicting women without HPV infections. We have specificity of almost above 98, 96. But majority of models failed to predict women with high-risk human papillomavirus infections, and this could be probably due to the low prevalence in our data set. So low sensitivity also has affected the precision together with the F1 score. On model comparison, because all of models has almost 0.68 discriminatory ability, we excluded the study ensemble model because we hoped this could outweigh these simple models, but it has similar performance. And we excluded naive bias in model comparison because this model showed low ability of predicting women with a high-risk human papillomavirus infection with almost perfect specificity. So we remained with the gradient boost machine together with the lasso to compare them which model could maybe optimized to be used in our clinical setting. So this is our LLC curve showing how our gradient boost machine together with the lasso performed in discriminating women with high-risk human papillomavirus infections or not. So we see both model has almost the same ability of discriminating women. Coming to the precision recall curve for the gradient boost and lasso, we see both model, they have almost the same area under the precision recall curve, showing that they both try to predict women with the true HPV cases without flagging those with the false positive. So in terms of comparison, we see like the area under the precision recall curve does not inform us which model is the best. Rather, we can focus with the lasso because this is the simple model. It is interpretable, and sometimes it can be easily adopted with the clinicians. Coming to the calibration plot, we see both model has nice calibrations from the probability, from low probability to almost 0.5 risk score, but they failed to have good calibrations from 0.5 and above. And our last model failed completely at this level to predict either to classify either women as high-risk human papillomavirus infections or not. But looking in our Blair score, we see both model has almost the same Blair score. In terms of choosing which model is the best, maybe to be optimized, still we remain with the lasso, since it's a simple, easy to interpret, and can be easily adopted. Now, our third objective was to identify predictors that's most likely to cause to tell us which women has high risk human papillomavirus infections. So we found marital status, especially those with who are married or cohabited, age, BMI, age at first sex. This shows to increase the risk. A potential predictor that increases the risk for women to have high risk human papillomavirus infections, while history of chlamydia, history of genital warts, together with the history of syphilis, this variable shows like there is a decreasing risk. They offer the decreasing risk for women to have high risk human papillomavirus infections, which has to be interpreted with the caution because it's against the biological reasons. Now, we tried to see how we can optimize our selected model to be used in our clinical setting using the decision analysis curve. And this is the line that has been used as a cutoff point. And our decision curve has proposed the cutoff point of 0.17 with the potential of net benefit of 0.04 or 4.3% as compared to 0.2% of our default cutoff point. So using our default cutoff point, we had a sensitivity, LASSO had a sensitivity of 0.04 sensitivity and the specificity of 0.99. But using our decision curve based cutoff point, we see our LASSO model will have 50% ability of telling which women has high risk human papillomavirus infection in reality, while balancing with the specificity of 0.70, ability of saying which women is truly having no high risk human papillomavirus infection. Coming to the confusion matrix, we see with the default cutoff point of 0.5, we can predict only 29 women out of our 617 that they have high risk human papillomavirus infections, while using this decision curve cutoff point, we can use our LASSO and we'll be able to detect about a half of those women having high risk human papillomavirus infection, showing the potential of being used in clinical setting, and then we can refer women for further testing. So this is our discussion. We see we have overall model performance of almost 0.68 to majority of models with overlapping confidence interval. So our findings are consistent to a study done in United States together with another study done in Turkey. And this is because both studies has utilized demographic, particularly behavioral and lifestyle variables to predict either women will have a high risk human papillomavirus infection. But our results are inconsistent with the study done in China, especially with Liu here together with Zhang, because this study, they have tried to use vaginal microenvironments biomarkers or vaginal infection biomarkers instead of using self-reported mostly variable or behavioral reported mostly variable to predict either women has high risk human papillomavirus infections. Yeah, and we are likely to choose our LASSO model as the best model because both model has almost the same area under the curve, and the LASSO model is the only model that can be interpreted easily. It is transparent to say why it has predicted these women to have high risk human papillomavirus infection or not, and it can be easily adapted in clinical implementation. Also, we have found that despite of using the default cutoff point of 0.5, that yielded the net benefit of almost 0.2% in prediction of women with high risk human papillomavirus infection. The use of decision curve analysis to find the best cutoff point with regards to our data set with a low prevalence has demonstrated that the use of 0.7 cutoff point is the best point that surpasses the strategy of treating all women or treating non-women. So our LASSO model can better be used to optimize the cervical cancer screening among women. This is similar to the study done in China and others. And lastly, we came to find that sexual transmitted diseases, marital status, age, number of partners, BMI, together with age at 56, there's a strong predictor that can predict either women has high risk human papillomavirus infection or not. But self-reported STIs history, especially chlamydia, syphilis, and genital warts, has placed these results against or inconsistent with the previous study or with the known biological plausibility. And we suspect that this is because to the nature of data of self-reporting, maybe there was a reporting bias, but also it might be those women with history of sexual transmitted disease, they have changed their behavior. Yeah, likely they have changed their behavior, they practice safe sex, or they have stopped some of practice. So coming to the strength, our study has been able to utilize large data sets from multiple sites, combining prospective data together with the cross-sectional. Also, we try to use the robust pipeline model in model building and model evaluation. And this study, by the way, it establishes the baseline or reference model for high-risk human papillomavirus infection predictions for triaging. And in terms of limitation now, the use of secondary data limited us to meet those highly biological plausible variables that are more likely to estimate the prediction of high-risk human papillomavirus infections. Also, we had the recall or social disability bias, mainly from these lifestyle-based variables and sexual transmitted infection variables. So we can recommend that our model may be adopted in clinical, in daily-to-daily triaging of women for cervical cancer screening, but complementing the existing screening program alongside with the continued retraining, recalibrating, and external validation of our model. But most important, we should enhance the use of biological biomarker, especially those of vaginal microenvironment, like those microbiota, the pH of the vagina, together with the vaginal infections, not by history, but by confirmed laboratory findings, will enhance the model ability to either tell us which women has high risk human papillomavirus infection or not. Then, based on our findings, we recommend, particularly starting with the future researchers, they should maybe focus on prospective studies on studying women behaviors and lifestyles that might maybe help us to predict women with high-risk human papillomavirus infection. Also, exploring the use of principal component analysis as the feature engineering approach, especially to these lifestyle-based variables and behavioral variables. Also, we recommend future studies to retrain and use prospective studies to validate either this our threshold suggested may be replicable for the new populations. Also, we recommend further studies to incorporate vaginal biomarkers and laboratory confirm the findings, maybe to help the model to learn from the quality data. Also, for the healthcare providers, we recommend them to adopt this tool as their complement without replacing the existing cervical cancer screening framework. And we recommend them to offer back feedback so that we can improve and refine our cost-effective triaging instrument. And to policymakers, we recommend a Ministry of Health together with other partners to sponsor further prospective studies that will help us to have evidence-based and more improved machine learning models that will help to enhance cervical cancer screening and early detection in Tanzania. These are the list of my reference. So I would like to acknowledge my supervisors, Professor Michael Mahan, together with Dr. James Ngocho. I would like also to appreciate my mentor, Edwin Sherio, KCLI for their support on working with this start together with the current study principal investigators and colleagues for giving me a chance to use their data for secondary analysis. Otherwise, thank you guys for your attention. I really appreciate to hear feedback, questions, and comments from you.
Wonderful. Excellent job, Yekonia. That was a really impressive work, and it's obvious that you've spent a lot of time and effort, which shows in how clearly you present the work. So congratulations to you as well as your mentors. We'll open up for some questions and suggestions, comments from folks smarter than me. I dropped a few things in the chat, but we can get to those if we have extra time.
Hi, great talk. This is Charlotte. I don't think we've met. I'm a neonatologist in the US, but I come to KCMC a couple times a year, so kind of adjacent to the women's health field. I have one like process question and then like a larger policy question for you, if that's okay. First, what is the like HPV vaccine uptake in Tanzania? Like
The
Like, is it-
prevalence.
yeah, do you know the prevalence of like the HPV vaccine?
Yeah, the prevalence of HPV vaccine nationwide, it has been documented to be only 7% based on
Okay.
the national survey that has been conducted in 2022.
Awesome. So obviously, like policy-wise, that's a big one. My question is like stepping back and thinking, because you seem to be like an expert and very focused on machine learning and how to integrate that. For cervical cancer screening and HPV screening, it's super treatable when caught early. And so I wonder how you think about like that. You made a great point at the end about we really need to lean into like biomarkers and that actual testing, but like the relative add of machine learning in diseases with really high cure rates with early detection versus like ones with lower cure rate. That's maybe like just a big level question, but I was thinking about that as you were talking, because I think even women who are low risk for cervical cancer absolutely should still be screened for HPV and treated if positive because the cure rate is so high. So in my mind, I was a little bit like, well, even low risk people should still be screened, even if the algorithm says they're low risk, because of how treatable and curable it is. And so I wanted to get your thoughts on that.
Yeah, it's fine. It's nice. Of course, we really like to make sure that every woman with the eligible age should be screened for high-risk HPV infections. But in reality, in our setting, there's HPV DNA tests, they are not available almost in every setting. As we speak now, almost 10 legions, approximately 10 legions out of 30 legions in Tanzania, they implement this HPV DNA test, and you might find only in few settings within a legion, maybe the regional referral hospital or these major centers for cervical cancer screening. And in rural setting, you might see this HPV DNA test, it's not available. That's why I thought the use of this model will help us not only to offer every woman to use the HPV DNA tests that are available, like we can use this model to see those with high risk, then we can offer them the priority of further testing or confirming using HPV DNA test. That was thought.
All right. I think we have time for another comment. Emily, if you wanted to chime in.
Charlotte had asked a question that I had about the HPV prevalence. It's nice to meet you too. I'm an epidemiologist here at Duke and with some work with kids cancer. So the cancer space just with children. But I'm wondering if you had any data on religion. Here in the US, it's such a huge marker on HPV diagnosis, stage that it's found. So I'm wondering if you had any of that data for religion.
Okay, regional-based data.
Yeah.
I'm sure there's data they are available, but because they are routinely collected data, we are so worried with their quality. We might face a lot of missingness. That's why during the conceptualization of this study, we focused only to use the project-based data because we are sure that this data they might have at least a good quality without high missings.
Okay, cool. It might be interesting to look to see what that missingness actually is for religion. It's pretty robust when we collect it for children's cancer. So I just wondered if it'd be the same for adult cancer. And it made me think of not just for the risk factors that religion plays with HPV, but also in the results where it said can you go to the slide that shows what increases or decreases the risk? It was a great slide.
The lasso.
It was in the bar
predictor.
chart. Yeah.
Yeah.
Okay.
Slide 30, I think, Yekonia.
We are looking for it.
There
This
it
one.
is.
This
Yep.
one.
It made me also think of, so what increases the risk of, is this of HPV infection? What is the outcome here?
Our outcome is HPV infection, by the way, high risk human papilloma
Yeah,
virus
so what
infection.
increases the risk is being married, cohabitating, which makes sense from a biological standpoint, but it also made me think when we see this here in the States for cervical cancer, it can also mean there's something else going on that makes someone increase their risk by like how they think about the disease. And a lot of times that's religion.
Yeah, I agree.
Good, thank you.
Yeah. Thanks so much, Emily. Thanks, Charla and others. I see some comments in the chat. Thanks for sharing. While we're on this slide, I just want to highlight one more comment that I put in the chat, and Maddie's going to share all of these comments with you, Yekonia, that are written. So if anybody else has any, please put in the chat. But I wanted to highlight on this slide, kind of to Emily's point too, to make sure that we're clear on the direction of the relationships, and that's especially for the categorical variables on this slide, especially because you noted that some of them have the way you described it as a counterintuitive relationship. Let's make sure that this is clear, that this is, higher age increases risk, or, higher BMI. History of chlamydia is somehow protected. Just to be super clear, I mean, I think it's obvious, but I'm not certain when I'm interpreting this. So that could be more clear in your labels. But we don't have time for too much more discussion. But again, everyone join me in thanking Yekonia for the great presentation, the great work, and we wish you luck as you go forward.
Okay, thank you very much for your.
Yekonia, can I just make one last comment to you? I would really like to invite you to come present